we're hoping to also vote on approving a new co-chair to join me as co-chair. We've got federal updates, as well as updates on the plan certification standard, state subsidy, and in a discussion at the end for strategic planning. So let's move on. If anyone was able to join last meeting, we have a lot of new members, so I encourage you to look at the list of people and see sort of all the diverse backgrounds that we have on the committee. Okay, so we'll vote to approve the meeting minutes from May. So I move to approve the Standing Advisory Committee meeting minutes from May 15th, 2025. Do I hear a second?
Second.
Thank you. Are there any objections? Great. Hearing none, we've approved the meeting minutes from May. Amelia, do we have a quorum for this now?
Amelia, you're on mute.
Thank you, Kimberly. I'll do a quick count now. I think we can at least go through introductions, and if I'll let you know if we don't have a quorum and maybe need to hold the vote for a little bit later.
Okay, so that sounds good. So hopefully once we're at quorum, we'll be voting on a co-chair to join me. Filling out, there's currently a vacant role here as stated in the bylaws. The members shall elect from their membership 2 co-chairs. Co-chairs so elected shall serve a term of no more than 2 years or until their own term of service on SAC has expired, whichever comes first. If a co-chair is elected to fill the unexpired officership of a predecessor, such service shall not count against limitation on tenure set forth above. The co-chairs of SAC shall, in addition to presiding at meetings, have such other duties as may from time to time be assigned by the MHBE board or otherwise prescribed by these bylaws. And so Amelia and Johanna and the MHBE staff recommended Stephanie Clapper from Maryland Healthcare for All, and I agreed with the decision to nominate her. And so, today, hopefully we'll be able to move to approve her as co-chair, but I'd like to give Stephanie some time to introduce herself and her experience and interest in the role.
Thanks, Mark. Hi, everyone. I know many of y'all. I've served on the Standing Advisory Committee with many of you for several years now. I have served on other Maryland Health Benefit Exchange work groups as well, such as the Affordability Work Group, the Easy Enrollment Work Group, Health Equity Work Group, and I've also represented consumers for other Maryland state agencies like the Maryland Healthcare Commission, the Health Services Cost Review Commission, and the Emergency Room Wait Time Group. So I would love the chance to serve as co-chair along with Mark for this committee. And for those of you who don't know me, I'm Deputy Director at Maryland Citizens Health Initiative. We are a nonprofit consumer advocacy group, and our mission is quality, affordable healthcare for all Marylanders. So thank you for your consideration.
And I'll ask if anyone else would like to put forth a nomination for the co-chair role. Okay, hearing none. Amelia, do we have a quorum to?
We do not. We have 10, I think, on, and we need 12. So I know a couple people are joining late, so we can push this to maybe the end of the meeting.
Okay, so we'll come back to this at the end and hopefully move to approve Stephanie, but we can move on for now. And we are also waiting on Michelle. Amelia. Amelia will give federal updates now. Thanks.
Thanks, Mark. Hi, everyone. Amelia here. I'm a policy analyst on the exchange. Normally, our policy director, Johanna Fabian Marks, would give federal updates, but she is also joining late today. So I'm going to do that portion of this presentation and give you guys an update on all the changes to the marketplaces that's been happening at the federal level. A lot of these things have just recently been finalized in the last month. So we'll just give you an overview of kind of what's going on and what the current landscape is right now. So the kind of first set of changes and new federal provisions came out of the Centers for Medicare and Medicaid Services Marketplace Integrity and Affordability Rule. This proposed rule was released back in March, and CMS received thousands of public comments in a really kind of short comment period window of around 23 days, including public comment from MHBE. We submitted comment on April 10th to the proposed rule. A lot of the comments pushed back on a lot of the provisions that were in the rule as proposed, or they advocated for continued state flexibility in how marketplaces operate, which were reduced under a lot of the provisions in the proposed rule. So this final rule was published by CMS last month. So it's been published as final, and it includes quite a few updates from the proposed rule. A lot of the updates revolve around including sunset provisions, sunsets on a lot of the provisions. So a lot of the provisions in the rule now end after 2026. And then there's a couple that had some pretty significant impacts that no longer apply to state-based marketplaces or give states a little more flexibility, which is a good thing. However, in general, the proposals in the final rule still add a lot of enrollment burdens to consumers. The provisions restrict eligibility for certain groups and reduce affordability. And overall, we're estimating that a lot of healthier individuals will roll off of exchange coverage as a result of these new provisions and new requirements that we have to implement, and will ultimately result in a less healthy and more expensive risk pool. So that's the CMS final rule. And then the second kind of set of provisions were included in, I think, what everyone's familiar with, the House Reconciliation Bill, the Budget Reconciliation Bill, which is more commonly referred to as the One Big Beautiful Bill Act, but we'll refer to it as HR 1 in this presentation. So this was signed into law just recently, earlier this month on July 4th. And the original bill included a lot of provisions that would have codified the majority of all the provisions that are in the CMS final rule. Most of those were included in the reconciliation bill. Fortunately, most of those were stripped out. However, there are still a lot of marketplace provisions in the reconciliation bill that remain and kind of generally fall into buckets of either rescinding eligibility for a lot of legal immigration statuses for marketplace enrollment, also adding a lot of consumer enrollment burdens. And then it still does codify a few of the provisions from the final CMS rule. The bill also, of kind of really important note, did not address extending the enhanced premium tax credits, which have been available to consumers since 2021. And they are set to expire at the end of 2025. And we've been talking about this a lot with the SAC and other stakeholders for the entirety of this year and last year. They will expire in 2025 or at the end of this year unless Congress takes action. So they weren't included in the reconciliation bill. That doesn't mean that action won't be taken later this year. Congress could still take this up later in the year. But it certainly presents concerns and challenges that this wasn't addressed in the reconciliation bill, because we know that their expiration will lead to very significant affordability challenges for a lot of consumers beginning as early as 2026 if these tax credits are not extended. So in the next few slides, we have compiled just a list and overview of all of these federal marketplace provisions that are in the CMS final rule and the reconciliation bill. And I'm not going to go through all of them in detail just because we want to make sure and leave time for any questions or discussions on any of them. So I welcome any questions on any of the provisions, but we'll kind of try to run through these efficiently. So the first set of listed provisions kind of fall into this bucket of impacts on affordability. So the way we've laid this out is the first column gives an explanation of the provision. The second one lists where the provision originates from. So either the CMS final rule, the reconciliation bill, or both. The next column shows the effective date of each of the provisions, which varies from some that have an implementation date as early as October of this year, others as late as the beginning of 2027 or even the beginning of 2028. And then the final column just kind of gives an overview of the impact of the provision on the marketplace. So the first one listed here, as mentioned, is the bill, the reconciliation bill, HR1, not addressing the extension of the enhanced tax credits, which we've estimated if they are not extended and they expire at the end of this year, will increase net premiums by almost 70% for the tax credit eligible consumers. And that will lead to very significant enrollment losses in the marketplace. We're estimating as much as 70,000 individuals will drop coverage due to affordability issues. The next provision updates the premium adjustment percentage methodology, which essentially just changes the way that tax credits to reduce premiums are calculated. And this update is estimated to increase net premiums by around 4.5% in 2026. So that's also a significant impact to tax credit eligible consumers. And the next provision expands the de minimis range for actuarial value beginning 2026 as well, which essentially just means that plans can be less generous and still meet these AV requirements. But the provision does clarify that states can still impose tighter limits on AV requirements. So we will give an update on how MHBE plans to address this in the next presentation. So I'll leave that there for now. On the next slide, there's a couple more affordability provisions. One includes removing the applied premium tax credit repayment cap, and instead requiring all tax credit recipients to repay the full amount of any excess tax credit that they received. This happens when someone's attested income is different from their actual income, and that's reconciled during tax filing. So this provision will remove the cap for repayment limits for everyone, regardless of their income. And there's currently a repayment limit or a repayment cap that varies based on household income. So this provision will remove that, and that can create some pretty significant repayment liabilities, particularly for low-income consumers. And then the next one is an affordability provision that prohibits the inclusion of gender-affirming care as an essential health benefit. That was in the final rule. It was proposed to be codified in the reconciliation bill, but it did not remain in the bill, so it's just been included as a regulation update. The next bucket of provisions relate to changes in eligibility, mostly restricting eligibility for marketplace coverage and or financial assistance for certain groups. So most of us are familiar, I think, with the first provision, which will rescind DACA eligibility for both marketplace enrollment and financial assistance. So individuals with DACA status had just recently been deemed eligible for marketplace coverage and financial assistance beginning November of 2024 of last year. So this provision is going to impact we have around 300 individuals with DACA status who are currently enrolled through Maryland Health Connection that will lose eligibility beginning, I believe, October of this year. I think maybe someone can correct me if I'm wrong, but that one has a pretty immediately effective implementation date. So we'll be working on consumer notices, outreach, making sure everyone understands what's going on here. And then there are a couple other provisions that relate to eliminating subsidy eligibility for most lawfully present immigrants beginning as early as 2026. So there's these two provisions that were in the reconciliation bill. The last one is kind of the more impactful one, and this will start 2027. It eliminates subsidy eligibility for most lawfully present immigrants. There's kind of a few exceptions, but it really reduces the eligibility for this population. And in general, kind of the bucket that it rescinds eligibility for are groups like refugees, asylees, and victims of human trafficking. So that provision will go into effect starting 2027. Another category of eligibility provisions, one rescinds the applied premium tax credit eligibility for failure to file and reconcile, which we term FTR, for failure to file and reconcile in one prior year. Currently, the rule denies APTC only if the IRS can't verify reconciliation for 2 years prior, given all the data and procedural constraints that go along with this. So this provision is reverting back to just the 1 year FTR policy. This one, I think this provision was in both the final rule and the reconciliation bill. So the final rule provision had a sunset date of 2026, but then this provision was codified in the reconciliation bill starting 2028. And then another provision will permit issuers to deny coverage to individuals for failure to pay past due premiums from a prior plan. However, this provision is still subject to relevant state law, so there's some flexibility there. And then the last bucket of provisions generally impact either enrollment opportunities or they increase administrative burdens to the consumer. So for example, the first provision shortens open enrollment periods. It gives some flexibility in how states can structure their open enrollment periods, but it generally limits OE to 9 weeks. And OE can extend only from as early as November 1st to as late as December 31st. So in Maryland, our OE currently runs through January 15th. So it'll be reducing our open enrollment period by 2 weeks. And that provision will is not effective for this open enrollment period, but will be for next open enrollment period starting 2027. And then I think this is, yeah, the second one down. The second provision is really kind of a major provision in the reconciliation bill that will eliminate both auto re-enrollment and conditional eligibility for tax credits or the subsidies for all subsidy eligible consumers who enroll through the marketplace. So currently consumers receive advanced payment of premium tax credits during the period that their subsidy eligibility is being determined. That can take, up to a couple months. And in the meantime, consumers can still receive APTC while their eligibility is being determined. So this provision will eliminate that conditional eligibility, and that can create initial cost barriers that will lock people out of coverage for a year if they can't pay their full premium in that time during the eligibility determination period. And it will also create significant enrollment barriers for the roughly 75% of consumers who are currently auto re-enrolled. That was the rough estimate for the number of MHC consumers that were auto re-enrolled in 2024 into their 2025 plan. So that poses a significant enrollment burden for both consumers and then for the marketplace as well, since we've historically process the majority of renewals as auto renewals each year, and that will be eliminated beginning 2028 for this provision. So that has some major impacts for both consumers and marketplace implementation. And then I think there is one more slide, the last kind of set of enrollment provisions. So I think I'll just go through the first one, which will restrict the marketplace's ability to just accept consumer attestation of income and it will instead create more income-based data matching issues, which will require consumers to submit proof of income, which they didn't previously have to do. We previously submitted consumer attestation of income, and it'll add a significant administrative burden on both the consumer and the marketplace as well. And then finally, I did just want to mention there are quite a few Medicaid provisions in the reconciliation bill as well. And we wanted to highlight a few that will have system impacts to MHBE because as the integrated exchange, we process the majority of Medicaid enrollments in the state. So a lot of these Medicaid provisions will have significant cost impacts on the exchange, in addition to all the impacts of reduced enrollment in Medicaid. So the first and probably most impactful one is the Medicaid work requirement, which will require states to implement work requirements as a condition of Medicaid eligibility for the ACA expansion population, which is roughly a quarter of Medicaid enrollees in the state. A second provision will reduce eligibility for retroactive coverage for all Medicaid enrollees from currently 3 months down to either 1 or 2 months, depending on your eligibility category. So that will, reduce access to Medicaid enrollment, and then pose a significant administrative burden on the exchange as well in terms of implementing these policies. And the third kind of major Medicaid provision will require states to increase eligibility redeterminations to once every 6 months for the ACA expansion population specifically. Currently, redeterminations happen annually, so this will be doubling the redeterminations each year. And again, all these will have system impacts on the exchange. So as we're working through these, we'll be working with the Maryland Department of Health and their Maryland Medicaid team very closely on implementation of all of this. So I think I will stop there. I listed a slide as well that has some great resources that provides pretty in-depth overviews of all these provisions, both for Medicaid and for the marketplace. So I just want to make sure that these are available to you as well. And I will end the federal updates there and see if anyone has any questions on anything. Yeah, Stephanie.
Thanks, Amelia. This is a really helpful chart. And especially appreciate the effective dates listed for everything. I had a question about the conditional eligibility for subsidies for all subsidy eligible consumers. So if auto enrollment is not allowed anymore and it takes a couple of months for subsidies to be for people to know if they're eligible for subsidies, does that mean that like everybody is going to have to be paying full premiums for a month or two at the beginning of the year, or is it like a subset of consumers that will have to do that?
Yeah, I mean, that's essentially the impact of the provision is if it takes, in the period of time it takes to affirmatively verify income, the consumer is not eligible to receive APTC at that point. My understanding is they would still get retroactive coverage, but that would hold them liable for the full premium amount for those first, however many months that the eligibility determination takes. So it has a significant cost impact on consumers that may not be able to afford the full premium and would, as a result, not effectuate coverage or disenroll.
And would they then get, if they're found eligible, would they get like that money back or like a discount on the future months for their premiums, or is it just their money is just gone?
That's a great question. I don't think I know how that process works. I think there's quite a few implementation questions on a lot of these provisions. I'm not sure if anyone on the call right now would know that, but I personally am not familiar with how that process would work, and I'm not sure if it's been spelled out. that's a good question.
think there's
Amelia, this is
language.
Michelle. I can just jump in quickly on that. Because everyone would reconcile their premium tax credits when they file their taxes, I suspect at that point in time, if they were eligible for it but did not receive it, they would probably receive it at the time when they file their taxes. It will be considered at that moment in time.
Thank you.
Yeah, Mark.
Yeah, I'm curious about the Medicaid work requirements or the Medicaid provisions in general, and like what MHBE's role in particular will be, and I guess trying to mitigate the administrative burdens with the enforcement of the work requirements. Like my view of when they did in Arkansas and all that is that most people actually would have met the work requirement criteria had they actually finished the paperwork. And so, how can the state sort of prevent those people from sort of being deterred by the ordeals? And then I'm also kind of curious about the italics here about the, a good faith effort and what that might mean.
Amelia, if you'd like me to address that, I can do it as part of my update because I've already got that in as part of my update.
Absolutely. Yep.
Sure.
Happy to let you do that.
All right, so I'm going to jump in, and I'm sorry I'm late. I'm actually at Maryland Healthcare Commission doing a presentation similar to what you're getting on the final rule and the budget. So you've heard from Amelia all the things that are going in, the timelines that are going in. I have to say that I'm incredibly proud of the work that the Maryland Exchange did in collaboration with our fellow state-based marketplaces across the nation. We have both on the proposed rule and on the bill. We've been meeting with CMS, with the CMS administrator, Peter Nelson. We've done an awful lot of education, supplying data about the impacts of the proposed rule, trying to clarify with Administrator Nelson that the fraud that is being seen is not what on the state-based marketplaces. It's more prevalent on the federal marketplace. So we actually were able to change both the final rule to get changes. He listened and gets more flexibilities for state. Of course, we're always talking about state flexibility. So in the final rule that Amelia just went over, we actually were able to affect that final rule. Likewise, with the HR1, we did a lot of education on the provisions that were built into that and how they would affect marketplaces. And we were successful in getting some of those. They took them out based on the educational materials and the numbers and the data. And it's been a lot of work over the last several months of pulling data, sharing data, getting data. But I think we all should be really proud of what we've done to really make a difference for Marylanders. And the next thing, the big thing for us out of the HR1 is the fact that they did not have the expanded tax credit in there. So we know without that, we're going to have significant impacts, not only to our enrollments, but to the individual market risk pool as a whole, to the reinsurance pool, the reinsurance funding that would come through from pass-through. So that is still something we're trying to keep, front and center on everybody's radar, that renewal notices will be going out to consumers in September-October timeframe. And without those tax credits expanded or continued, we anticipate some consumers would have 68% increase in premiums. So that's a full focus on ours. And then the final federal update that I will share is to your point, Mark. So let me just again explain the relationship. So the Department of Health is a designated state Medicaid agency. They are responsible for policy interpretation, for defining what the requirements are going to be for things we have to do. Through an interagency agreement, they have delegated that the eligibility enrollment functions, the IT functions, a wrap around consumer support functions to the exchange. But we don't have that authority to make determinations on how that policy is interpreted. So as Amelia said, we are working very closely with MDH and going, to interpret what that policy is. The only little saving grace is that the deadlines are out a little bit further. So we have more time to work on that, figure out the costs. Of course, right now there are some implications that will significantly affect the Medicaid funds coming in, but those are all things that we are, through our agency, through Department of Human Services, MDH, everyone's working together to try and figure all that out as we can. Does that answer your question on that, Mark?
Yes, thank you.
Okay. And then I'm going to move into just some state updates. Again, as I said, the biggest low-hanging fruit for us is what will happen with these expanded tax credits, as well as we have about 300 DACA recipients that are receiving coverage that the final rule or the final the bill sunsets that coverage on, I think it was it the rule or sometimes I get them mixed up. Anyhow, it sunsets, that was in the final rule. It sunsets August 25th. So now we are shifting gears of how are we communicating that. Our marketing team has been putting together some comms that will start to go out next week saying, we're encouraging you to let us help you find other sources. We're encouraging you to get whatever medical treatment you need now before this coverage ends. So that will start some communications. We're also working on how are we going to communicate and message the impact of the expanded tax credits are not extended, and what do we do around retention and trying to keep people retained in that. So let's see, we are really concerned about our immigrant community and some of the things that Amelia has talked about that are coming up, not so immediately, but some in January and then others later on will be an issue. I'm going to shift into board and MHB updates, agency updates, and I'll come back and take all questions. On Monday, we have our annual all-day board and leadership planning session followed by a board meeting. And we actually, believe it or not, we have 5 of our 9 board of trustees are new this year. So we will be spending the morning really doing deep dive into training and education 101. What is the exchange? What is the board's authority? How they exercise that authority, procurement policies, communications policies. So a lot of training on that in the morning. Let's see. We are also in the midst of preparing a new 3-year strategic plan. Our last plan was 22 to 25, and we're winding that down. And so we're working on looking at the new strategic plan. And then for the meeting, the board meeting on Monday, which is going to be a little bit heavy lift. You'll hear some of it today. We have a software procurement, but then we also have some the final 2026 state subsidy and reinsurance parameters that you're going to hear about, the additional plan certification standard, and final regulations on consumer assistance that the board will have to take action on. And then I'll just wrap up with some updates from the exchange. We have a lot of staffing changes going on for all the right reasons. Betsy Plunkett, our Director of Communications and Digital Strategies, is retiring. Her last day will be next week. And one thing that the leadership team really does well is work towards succession planning and making sure we have bandwidth and training and people, ready that can move up into other roles. And I'm pleased to announce that Maggie Church will be the next director of marketing and communications, digital strategies. And then we also promoted Teresa Battaglia, who is our small business manager, to the deputy director. So we've really done some reshuffling there, all great, competent, super people. Let's see, we have Andy Ratner, our chief of staff, is retiring the end of October. And so we still have time to celebrate him and thank him for all his work. And Johanna Fabian Marks, effective July 1st, is now the Deputy Executive Director at the Exchange. So our team is staying focused and working really hard to make sure that we fulfill our mission of keeping people covered in health insurance. And then one other announcement, because I just heard it today here. MHCC has announced their new executive director, Dr. Jacobs. And when I introduced myself, he said, "Oh, I've worked with Johanna in Pennsylvania." So again, more small connections in the world we work in. So I will stop there for the executive update and happy to try and answer any questions. Stephanie.
Well, Michelle and everyone at the Exchange, congratulations to those retiring and those who are stepping up into new roles. Thank you so much for all of the intense advocacy that you have done and continue to do at the federal level. And I was just wondering if there are any examples in particular, things you were able to change that you're particularly proud of.
I would say the biggest one is more flexibility. So originally in the open enrollment is a really good example, right? It was going to be November 1st to December 15th. And it got extended to December 31st and with flexibility for exchanges. So that was really good. And the other one was some of the verifications for that really were an issue on the FFM. The exchange state-based marketplaces are not going to have to do those. So they're going to have the FFM focus on them, and some of those are a limited duration. So probably those two. I see Johanna's on, and Amelia, you may have other thoughts as well, but that's my initial thought. All right, if there's no other questions for me, I'm going to drop off and go back and do my presentation at MHCC. And thank you all for joining today.
Thank you, Michelle. Okay, so I think we'll proceed to the next update on plan certification standards from Becca Lane.
Thanks, Mark. Hi, everybody. Can you hear me okay? Okay, good.
Yes.
Just want to make sure I've got headphones in today. So as Amelia mentioned, one of the provisions of the final rule was widening the actuarial value de minimis ranges for plans for 2026, the 2026 plan year. So this is, and the way in which the ranges were widened was by lowering the floor for AV. So this basically just means that for 2026 plans are allowed to be a little bit less generous and still meet federal requirements for plan generosity. So this was, since the rule was released so recently, we are introducing kind of a last minute update to our plan certification standards for 2026. And yeah, we're doing this because we think it's important for promoting market stability and reducing uncertainty going into the 2026 plan year. There are a lot of other changes happening. And our plan review process is already underway for 2026. And so this is just something we felt was important to take to the board. So on the next slide, I can give a little bit more background. So yeah, as I mentioned, our plan certification standards for 2026 have already been finalized. Technically, that happens in February each year. And so the standards that we finalized include value plan standards for 2026, and then also this requirement for mental health cost sharing and requiring that mental health copays be the same as they are for primary care. Technically, yeah, I don't need to go into that right now. That's what our 2026 plan certification standards were. But then in June, late June, CMS finalized this rule, as I mentioned, widening the de minimis ranges. On the next slide, yeah, so for those who don't know, I'll just explain the de minimis ranges a little bit. So these just describe how much a plan can vary from the specified level of coverage for each metal level. So AV it just describes plan generosity. So bronze plans can be that. So it means that for bronze plans, for example, 60% of the care the insurer pays for, and 40% the consumer pays for. And then for silver plans, the insurer pays for a little bit more, and for gold plans a little bit more. And for platinum plans, the insurer is covering the most compared to the consumer. And under 2025 rules, a gold plan could have an AV, even though the idea is gold plans have an 80% actuarial value. Technically, the generosity could range from 78% to 82%, so -2 or +2, around that 80%. Under the 2026 rules, from the final rule that came out in June, a gold plan could actually have an AV of 76%. So our proposal is that in Maryland, the generosity floor would remain how they were last year. So for this gold plan example, the floor is 78% rather than 76%. Hopefully that makes sense. Next slide, please. So basically, if the board votes to approve this, we'll consider it as final and in effect for 2026. I should mention though that one of our carriers did file under the assumption that they would be allowed to use the de minimis ranges that the feds had proposed. And so that carrier would need to refile their plans. And so, yeah, if the board approves the standard, then that's what would need to happen. But it's only one of our carriers. I think that's all the info I have for you. Yep, that's it. So thank you.
So I think our next is the state updates on the state-based subsidy, which I think is also we have at least on the agenda for Becca as well to lead.
Johanna will be giving this.
Oh, Johanna. Okay, great. Johanna, are you able to, or?
Hello, can you hear me?
Yes, welcome. Hi.
Okay, wonderful. And I'm sorry to be off camera, but happy to have the opportunity to present on our state-based subsidy and what we're thinking about what we'll be doing for 2026, what we're going to be discussing with our board on Monday. So I think we can go on to the next slide. So quick background here, as many of you are familiar. The enhanced federal tax credits, which were put in place by Congress in 2021 during COVID, are going to end at the end of this year unless Congress acts to extend them, which is looking very uncertain at the moment. If they do act, it's possible that may happen around the September timeframe. So it's still a fluid situation, but under current law, those enhanced premium tax credits do expire at the end of this year. And as of January 1st, 26, they'll revert back to the levels they were at in 2020, before 2021. So the loss of those enhanced tax credits is going to directly increase premiums for the 190,000 of our enrollees who currently get those tax credits. They're going to lose either some or all of that monthly premium reduction that they benefit from. And it's a significant change. We estimate that on average, people's out-of-pocket costs for their premiums will increase by 68% for those who are getting those tax credits when those tax credits drop down to the 2020 levels. In foresight, in their foresight, the legislature authorized the exchange in this most recent session to establish a state-based subsidy program to mitigate the impact of these premium increases. And we do expect that if the state were to do nothing and we just let premiums increase as they would in 2026, that we'd be looking at losing around 70 to 80,000 enrollees, because that sharp spike in premium would just be unaffordable for them and they would choose to drop coverage. So thanks to House Bill 1082, we do have this authority to tap into our reserve funding that has been built up for our affordability programs to support the market for 26 and 27. If Congress does act to extend the enhanced subsidies this fall, our authority to enact this program is negated. That would be a happy situation if Congress fully extends them. So I would be happy to turn back the tide on this program, but we'll see where we come to. Next slide. So all of our affordability programs, which are reinsurance, the young adult subsidy that is now in its 4th year, and the upcoming larger individual subsidy for all ages, are being funded out of the same funding source, which is the 1% premium assessment on health insurance premiums in the state. The young adult subsidy, we are proposing in the kind of leading scenarios we're taking to the board, we would not be operating the young adult subsidy as its own individually named program. It would be folded into this larger individual subsidy program. Both options that I'll be discussing more as I go along incorporate the increased young adult subsidies, but they are just one component of a broader subsidies proposal for all ages. Our state funds are insufficient to fully step in for the loss of the the higher premium tax credits. We show 196. I think our estimate actually went up to about 209 million per year it would take to replace those. That's not affordable for this state. So we've modeled many scenarios to game out how we can most efficiently use the funding that's available to us. And we have considered, as part of these scenarios, adjusting the scope of the reinsurance program to potentially shrink the reinsurance program somewhat by increasing the attachment point in function, kind of somewhat reducing the money that we pay out through the reinsurance program in order to free up some more funding for the state subsidy program. So one of our two options takes that approach, the other does not. Next slide. And then something that I want to note sort of at the outset as we go through these options is that the HR1, the budget reconciliation bill, just recently passed into law a couple years ago, would limit lawfully present immigrants' eligibility for tax credits. The most immediate impact at a broad scale, there's some more immediate impacts to our DACA enrollees who will lose eligibility in August, but that's about between 200 and 300 individuals. Still, a very important, meaningful impact to those individuals, but a broader impact as of January 1st of next year. Lawfully present immigrants who are under 100% of the FPL and currently ineligible for Medicaid due to requirements that they have that lawfully present status for 5 years before they can be Medicaid eligible. Those individuals can qualify for premium tax credits to get subsidized coverage through the exchange. They will lose that eligibility for the federal tax credits as of January 1. Our data indicates that's around 20,000 individuals who would lose their eligibility. We did not model that population fully replacing their premium tax credits in order to get them to a fully subsidized status, which is essentially what they are at currently. And it would be very costly to step in and replace the federal funding that they're losing. We estimate about more than $150 million per year. So that impact is not reflected in all of the modeling we're presenting. So if essentially the scenarios that we propose do not replace the lost premium tax credits for this population, because if we were to do so, it would be roughly the cost of the entire program that we're contemplating currently. So I wanted to be kind of transparent about that and share that before we continue on. Next slide. And we can just go one more. So the legislation, House Bill 1082, laid out 4 priorities for the board of the exchange, which is the who will be determining the subsidy, the shape of the subsidy. 4 priorities for them to consider as they design it. 1, to mitigate the reduction in federal tax credits, of course, to maximize enrollment in the individual market as kind of like the marquee indicator of, is the subsidy achieving its goal? And then considering the state funds necessary to make sure that the reinsurance program can continue stabilizing the market through the end of 2028, which is that currently approved period we have under our federal waiver for it to be implemented. So not to say that the reinsurance program will end at the end of 2028, but that's the period that it's currently approved through, and the state will need to have a conversation in 2027 about the future of the reinsurance program. So right now, our kind of horizon that we're focusing on is through 2028. And then to the best of their abilities for the board to account for many uncertainties going on in the healthcare landscape at the moment, in Medicaid in the individual market due to changes primarily at the federal level. Next slide. So we have a few reference slides here to provide some baseline context for the conversation. You can see here how we're going to be talking a lot about different percentages of the federal poverty level. So this chart shows what do those FPL levels mean for a household of 1 or a household of 4 at different marks. So for a household of 1 at 200% of the federal poverty level, that's around $30,000. For a household of 4, about $64,000. At 400% of the federal poverty level, that's a little over $60,000 for an individual, a little under $130,000 for a family of 4. So just some reference points, so we're not just talking percentages. Next slide. And then another sort of descriptive slide for reference is when we're talking about those 190,000 individuals who will be experiencing the premium increase. This is a breakdown of who they are by both age band and income as a percent of the federal poverty level. So you can see under 200%, the 2 leftmost columns, we've got about 85,000 enrollees in that bucket. That's a big chunk of our enrollment concentrated at the lower income level, and then roughly fairly similar chunks in each income bracket going up, including about 23,000 individuals over 400% of the federal poverty level who are receiving premium tax credits. Prior to 2021, there was a cliff. If you were over 400% FPL, you were ineligible for tax credits. So sort of an indicator that there is still a substantial population that's paying a lot for their insurance over 400 that is currently benefiting from the enhanced federal tax credits. Next slide. So there are a number of things that we're considering as we worked through many scenarios of how the subsidy could be designed. And those key considerations are broken down into these 3 buckets. One, how does it impact the individual market from, how is it reducing people's net premiums, meaning the amount they pay after they get tax credits and subsidies, what the amount they're actually paying out of pocket. How's it impacting enrollment? As I already mentioned, that's explicitly one of the priorities in the legislation. And then how does that impact silver loading, which I'm not going to get into in detail in the interest of time, but it's sort of a wonky policy issue that has to do with premium relativities between silver and gold plans. And I will leave it at that, but happy to answer questions about it. The second bucket of considerations is, of course, how much is this program going to cost the state, and can we afford it given the reserves that we have in our fund funded by the premium assessment? And then third, how is this going to impact the reinsurance program, which is the other large affordability program we're operating out of this same funding source? So how's it going to impact the cost of the reinsurance program as we retain people in the individual market by reducing their premiums, reducing enrollment losses, which are all good things we want? That also means that they are more likely to have high claims and get trigger payments through the reinsurance program. So it can be some upward pressure on reinsurance costs relative to if people just dropped coverage. How's that going to impact pass-through, which is the terminology we use for federal funding we get to support the reinsurance program, which covers, roughly 70 to 80% of the program cost. As we keep people in the market and they don't drop coverage, we get more pass-through because we get pass-through sort of on a per enrollee basis. So by operating the subsidy program, we can actually increase the pass-through costs, which helps offset the overall cost of the subsidy. And then taking that all into consideration, how is that impacting the fund balance that is funding all of our affordability programs? Next slide. So I've been talking about the reinsurance program, and I think most folks on this call are familiar with it because we've talked about it a lot as a body, but just as a quick refresher, the reinsurance program, the state operates to basically reinsure individual market insurers, both on and off exchange. So when those insurers have individuals who incur a lot of claims in a year, the state steps in and reimburses the insurance companies for a portion of those high cost individuals' claims. And the amount that we reimburse per person to the insurance companies is determined by 3 parameters that are set by the board each year. One, the attachment point, which is the point at which when someone hits the attachment point, the reinsurance program kicks in and starts covering a portion of their claims. The coinsurance rate, which is the percentage of claims that we cover as a state after the attachment point is hit. And then the cap, when for that individual, we stop covering claims and the insurer is then fully on the hook for their costs. For most of the reinsurance program, we've had an attachment point of 20,000, a cap of 250,000, and a coinsurance rate of 80%, meaning if someone has between $20,000 and $250,000 in claims for the year, the state will cover 80% of their costs within that window. If someone has $15,000 in claims, the insurance company fully covers those. If someone has $1 million in claims, the insurer is on the hook fully for all claims over $250,000. But for claims within that window, the state reimburses carriers. Functionally, that works out to the state covering about 1/3 of claims in the individual market. That means that premiums are about 1/3 lower than they would be if the reinsurance program didn't exist. And the cap this year is the attachment point this year is $21,000. We had embarked on a plan with the board that we would increase that attachment point by $1,000 per year going forward, which would put it at $22,000 next year. This allows the scope of the program to sort of keep up with inflation so that the program doesn't just grow and cover a bigger and bigger percentage of claims over time. However, one of the subsidy scenarios, as we'll get into more detail, involves increasing that attachment point from 22,000 to 30,000. That means the state is spending less on reinsurance, which means that the state could divert money towards subsidies. But once we increase that attachment point, once we are spending less as a state on reinsurance, that also puts upward pressure on rates. So that's going to drive rate increases from carriers because, say, we're going from covering 30% of claims to, say, for example, 25% of claims. That means carriers are going to build in perhaps a 5% rate increase, and that particular rate increase can vary depending on the carrier and how many enrollees they have that qualify for reinsurance. So even though we might shrink the size of the reinsurance program so that we can spend more on subsidies, that can sort of have the knock-on effect of also increasing premiums. So it's all very connected. Next slide. This is just a quick note for reference how our attachment point compares among states nationally. It is actually among the lowest. This is I think 2023 data. It's the most recent national data we could find, but I don't think that the relativities have changed substantially. You can see Maryland over on the left with one of the lowest attachment points, and we do have one of the most generous reinsurance programs in the nation, which has had its benefits. We also have some of the lowest premiums in the nation, consequently. Next slide. So you can see here, I'm not going to go through all of these, but we modeled something like more than 10 plus different scenarios to try to zero in on the options that we were going to propose to the board. We put these out for a public comment and sort of had many conversations with the MIA and with our contracted actuaries to try to zero in on where do we think we could kind of meet the goals of the legislation and spend our resources efficiently. And zeroed in on two scenarios here, which were in the initial scheme when we had many, 4A and 4E. We have since kind of narrowed down, and our nomenclature for them will be A1 and A3. So just to kind of a little bit of confusion over how we're referring to them, but we're going to refer to them as A1 and A3. And they are very similar in how they treat everyone under 400% of the FPL. I think if we would fully replace the loss of enhanced tax credits for everyone up to 200% in FPL. So our lowest income consumers would feel no impact from the federal loss of tax credits. For everyone above 200, well, no. So for 200 to 250% of the federal poverty level, we will phase out from that full replacement at 200 to a 50% replacement at 250. And then from 250 to 400% of the federal poverty level, we would do that flat 50% replacement. In the first scenario, that is it in terms of who we are subsidizing. So we have that cliff of 400%. We are not providing a state subsidy over 400%. We also keep the reinsurance attachment point at the 22,000 initially planned. So we're not changing, we're not shrinking the size of the reinsurance program. And built into this subsidy scheme, we maintain the young adult subsidy. So we continue to offer enhanced subsidies for young adults, although it would be operated, as one overall subsidy program, but there would be a kind of a boost for young adults. In the second scenario, A3, it's identical to the first, except we extend the state subsidy to individuals over 400% of the federal poverty level. So those who are currently eligible could continue to receive it, who are over 400 at the 50% replacement rate. But in order to afford to do that, because that is rather costly, we also increase the attachment point for the reinsurance program to $30,000 so that we can free up some funds on the reinsurance side to provide the subsidies to the over 400%. Next slide. I'm not going to dwell on this slide, but it provides a sense of the architecture of how the subsidy would be designed. You can see on the EAPTC continue column towards the left, those are the current percentages of income that someone, household income that someone is expected to contribute to a benchmark plan. If their plan costs more than that, the federal tax credits make up the difference. So you can see at the 400% level, for example, and above, you're expected to contribute 8.5% of your income. If the benchmark plan costs more than that, you get the difference in tax credits. If and when the enhanced tax credits go away and the EAPTC expiration column, you can see there is no longer a subsidy for those over 400. And at the lower end, from say the 0 to 130 or 150, your expected contribution increases from 0% to up to 3.5%. So you can see in our 2 state subsidy scenarios, in those, up to the 200% FPL level, we are still keeping that same expected contribution that is currently in place. And above the 200% level, we are providing a portion of the subsidy, so that individuals' expected contribution increases relative to where it is now, but it's less than it would be if we had no state subsidy and we were just reverting to the old federal subsidy scheme. Next slide. Well, then this is just a note on how the young adult subsidy program works, and we would continue to incorporate this within the overall state subsidy. So I was just talking about how you have that percent of expected contribution of your income. We would reduce that percent of expected contribution of your household income by 2.5% if you're between the ages of 18 to 33. And then that phases out through age 37 until when you're at 38, you get no extra subsidy as a young adult. So this young adult subsidy is built on that architecture of expected contribution that was on the previous slide. Next slide. So this is a summary. The 2 highlighted rows show some summary information about our modeling of these 2 scenarios as compared to a scenario on the top line in which we did nothing as a state and the enhanced tax credits went away, and a second line if the enhanced tax credits were fully replaced. I will note that second line doesn't include the young adult subsidy. We were just sort of had so much modeling going on that we didn't model a scenario where we fully replaced the enhanced tax credits and continued the young adult subsidy. So it's not completely an apples to apples between the full replacement scenario and our subsidy modeled scenarios, but very close. You can see also that we, as I mentioned, indicate what the reinsurance attachment point would be in each of the 2 scenarios, and then getting into what do those scenarios mean for the state and for the program. We've got the program cost, which is what we anticipate, what we project we would be paying out in subsidies to insurers on behalf of enrollees, which ranges between about 130 and 147 million. And then we have what the net cost would be. And the net cost is much lower than the program cost because we are getting federal pass-through funding as a result of keeping many more individuals in the market. So when we offset our program costs by the additional federal funding, we'll get, as a consequence of that program, that's how we get the net cost. In the next column over, we have what we anticipate our total individual market enrollment would be. And so you can see if we did nothing, we anticipate we would have about 243,000 individuals enrolled. If we fully replaced the subsidies, we anticipate we'd have about 312,000 individuals enrolled. This is both on and off exchange, so total individual market enrollment. And then you can see that our projected enrollment for the two subsidy scenarios is very similar, a little over 300 million, meaning a roughly 3% reduction relative to that full replacement scenario, as compared to a 22% reduction if the state did nothing. So both scenarios, I think, are strong options in terms of maintaining enrollment. They really mitigate those enrollment losses. Last element of this chart is, where does that leave the fund balance for the program? At the end of 2027, and this is assuming that we operate each scenario in with the same parameters for 26 and 27, we anticipate ending 27 with between $40 and $68 million still in reserves. I will focus a little less on the end of year 2028 numbers because those numbers are a bit artificial. They assume current law, which we typically do in our modeling, but given that, they assume both that the enhanced tax credits have vanished and that our state subsidy program completely ends in 2028. And consequently, there's significant enrollment losses. We lose a lot of pass-through funding. It would be challenging for the reinsurance program. I expect that the state would, the board and the state will take action over time before we wind up in that situation in 2028. That could include shrinking the scope of the subsidy program in 2027, or shrinking the scope of the reinsurance program, or exploring additional ways of funding the reinsurance program for 2028. So there are, different levers that could be pulled so that we don't end up in that 2028 scenario. And again, even if we just were to continue offering some level of state subsidy, we would be likely not experience such a decline in the reinsurance reserves because we would still be getting additional pass-through funding. So for my purposes, I'm focusing more at this time on the end of year 2027 numbers and wanting to make sure that those at least are still in the black. Next slide. Okay, I think this is the last really substantive slide that I will talk through, and this has to do with the rate impact of the two scenarios I mentioned. This is some very draft numbers developed by the Insurance Administration to help us quantify where rates might, lots of asterisks. This is no guarantee of where rates might end up, but what the potential impact could be on rates of these two scenarios. So as rates were filed by carriers, and so rates are proposed to MIA in May, there's an extensive review period, and those end up getting finalized and approved by the Insurance Administration in the fall. They were proposed a roughly 17% increase. That's assuming that the enhanced tax credits end. A lot of people drop out of the market. The people who remain are sicker. That's driving these increases. If those enhanced tax credits were extended, then we see a rate increase more in line with trend, a little under 8%. And then two estimates for each scenario, scenario 1 and the second scenario, scenario C. So under the first scenario, where we maintain the attachment point at 22,000, we're looking at probably about a 10%, possibly, again, all the asterisks is a 10% average rate increase. That could potentially be much closer to what was filed, perhaps in the realm of 18%, if we go with the second scenario where we increase the attachment point to $30,000. Now, in that scenario where we're increasing the attachment point, we're simultaneously providing more subsidy because we don't have the 400% cliff. So it has an offsetting effect to the impact of the rate increase. These rate increases are really borne by people who don't get any tax credits, because those who get tax credits are largely insulated from these rate increases because of the value of the tax credits and then the state subsidy in the scenario where we're offering state subsidy. People who are higher income and don't qualify for those are the ones who really bear the brunt of these premium increases. So as I said, in the first scenario, the higher income individuals don't qualify, they lose presumably lose federal tax credits, and they would not be eligible for the state subsidy, but they have a lower overall rate increase likely. In the second scenario, there is a higher overall rate increase, but there is also potential eligibility for the state subsidy, although not everyone experiencing this rate increase would be eligible. It would depend on their income, household size, and their expected, what that expected contribution is for their particular situation. So I know that this is pretty wonky. I hope you are at least getting a clear sense that we put a lot of thought into this. We can go on to the next slides. I will, these are in the deck. I don't want to spend too much time in the interest of time on this, but it gives a sense of who would be most impacted in a baseline scenario where the state did nothing and the enhanced tax credits expired and the young adult subsidy expired and we had no state subsidies. You can see on the top set of numbers what the annual premium increase would be for someone in each age and income bucket. And below that, what that premium increase means as a percent of their income. And the heat map, the orange and red, clues you into who is experiencing the most significant impact, which with the loss of the young adult subsidy would be that young adult band sort of in the upper middle, and then the older adults who are just over that 400% cliff. Next slide. In this scenario, you can see because we're extending the young adult subsidy, we get rid of that big impact in sort of like the upper middle portion of the chart where the young adults are experiencing a jump. We still have a jump for older individuals over 400. And then in the last scenario, if you skip forward one more slide, you'll see it's not too different. We still experience that jump. It is somewhat moderated for the right over that 400% cliff by the state subsidy, but then individuals higher up the income range experience more of an increase relative to the first subsidy option. So I think that's a wrap on the meaty slides. We will, in fact, let's skip over these. I've already kind of talked at a high level about the enrollment impacts. We did solicit public comment. We got public comment from several insurers and then from some other individuals. I would say the public comments we got were in support of one of the two options that we're bringing forward for the board to consider. So it helped us narrow down which option. And I think there are benefits and drawbacks to each option, which are illuminated through these comments. And insurers tend to have different enrollee populations, which influences their perspective on which one of these would be better. We did also get a set of comments from our SHC chair, Mark, and his colleagues, which we really appreciate their review. They encouraged us to focus on targeting low-income enrollees, which we are doing in both subsidy designs that we're proposing. They encouraged us to prioritize that over the young adult subsidy based on their modeling. I think we are comfortable that we have the funding to support doing both, so we didn't feel like we had to take the either-or approach. And they reminded us that, to be mindful of the impacts of how we target subsidies on how that's going to affect our reinsurance pass-through funding, which is definitely an important component. And then we got a couple comments in support of the young adult subsidy. So I think that, I keep saying this, I think that's it. Yeah, so we're taking this to the board for consideration on Monday. We are also having a public reinsurance forum on the 23rd, which is something we do every year to talk about the reinsurance program and report out on it to the public. And we welcome participation from the SAC and all members of the public. And then I will just reiterate, this is still a fluid situation. Whatever the board decides on Monday, we may be coming back to the board in September or October to say something changed at the federal level. I would love to be able to say the tax credits were extended in whole or in part, and consequently we need to revise what we're doing as a state for a state subsidy program. We'll see how that plays out over the months to come. So I know that was a lot, but I would be very happy to take any questions or hear any thoughts from the SAC. Yes, me, Stephanie, and then Allison.
I've talked a lot. Why don't you go first, Allison?
Sure. First of all, thank you for all the extraordinary work and detail in this presentation. I just really appreciate seeing all of the data and the nuances and assumptions. Can you go back to the slide that compared the rate increases? I just wanted to make sure I heard it correctly. Is it that 1A and 1C? 1A and 1, does that correspond with A1 and A3?
That's right, yes. Sort of
Okay.
option 1 and option 3, which is our second option. The nomenclature got confusing.
Okay. Yeah, I just wanted to make sure I understood that correctly. Thank you.
Well, first, I just wanted to say thank you, MHBE and MIA, for all of your work. I can see how much work this is. I'm sure I can't even imagine how much work went into all of this modeling. It's very appreciated, and also thank you for incorporating the young adult subsidy in these two models that are being considered, and the needs of low-income Marylanders. This is a really tough balancing act, and we've done such great work in Maryland already in the years leading up to this, making coverage more affordable for young adults, and thereby stabilizing the market for everyone by encouraging younger and healthier people to come in. I had a question about, it looked to me like A1 and A3 are pretty much the same for folks up to 400% of the federal poverty level. And then, if I'm interpreting correctly, even though rates would go up under A3, that the out-of-pocket premium costs would be lower under A3 for people over 400% than under A1. Am I interpreting that right?
So you're right that for people under 400%, A1 and A3 are very similar. And it is really the difference primarily comes in for people over 400%. And it's the state subsidy that extends above 400% in A3 will not insulate everyone over 400 from the higher rate increase. What it does is it somewhat smooths the impact of that higher rate increase, but it's really kind of a trade-off. So you are going to qualify for that state subsidy if you're over 400% if your premium is more than about 11% of your income. So you could experience that rate increase that may push your premium up more, but not as high as being 11% of your income. So the state subsidy won't trigger an offset. It's primarily older individuals in the 55 plus group who end up with those high premiums because of age rating, where they're more likely to trigger the subsidy. So it is a tricky trade-off. And I think, ultimately both are strong options. It's just, do you want on one hand to have a lower overall rate increase to hit the higher income population, but they're not going to get any subsidy? Or are you willing to take the higher rate increase of A3, knowing that the subsidy will soften that rate increase for some, but not all individuals?
Okay, thank you. That helps. And then I had two more questions. One was for folks, I guess, are you anticipating that some folks who are going to be locked out of APTCs under the reconciliation bill and the final rule, like immigrants that have been locked out of APTCs, might be looking for full priced coverage from the exchange, and so rates should be considered when we're thinking about that population?
Because that population is under 100, I think that a very small portion of them, under 100% FPL, a very small portion of them are likely to be able to afford full price coverage.
Thank you. And then the legislation that created the ability for Maryland to create this new state subsidy program, was that legislation really only directed at APTCs not being renewed? And does Maryland have the authority to direct subsidies towards that immigrant population less than 100% of the federal poverty level, or it's only for folks who are affected by the enhanced APTCs expiring?
I think I'd have to go back to our legal department for a confident answer on that. I think in general, the legislation gives the board a good bit of discretion on how they design the subsidy program, but I don't think I could say definitively. But given the late breaking finalization of HR 1, compounded by the cost of replacing the subsidy for those individuals, is the result is that we didn't include that in our modeling. But it's certainly not an outcome anybody wants for those individuals to lose coverage.
Thank you.
Any other questions for Johanna? Great. Amelia, should we try to do the co-chair vote now, or should we save that for the end?
I think yes, maybe we could try. I can see 11. I think we need 12 SAC members. I can see 11, but there are a couple people who've joined by phone. So if you are an SAC member who's joined by phone and are able to announce your presence, could you please do so? There's one number that starts with 240 and ends in 11, and then there's another number that I see just left. But if the individual with the starts with 240, ends with 11, if you could just state who you are.
And they might have to hit *6 to unmute. I know I've run into that when I joined by phone before.
Thank you, Stephanie. If you can *6 and let us know who you are, we can see if we have a quorum. If not, I think we will have to leave the co-chair vote for the next meeting. So I would just want to reiterate my support for Stephanie. She's been a great partner at the exchange for a long time. If anyone would like to submit other nominations, please feel free to do so. You can reach out to me directly, and we can pick this back up at the September meeting to confirm the new co-chair. And then, Mark, I can go ahead and get into the discussion and conclude everything.
Sounds good. Okay, thanks.
Great. So I think in the interest of time, we ran just a little bit over, and I know that there was a lot of information that was presented today, all the federal updates, and then all of our updates with the state subsidy. There's a lot going on, and I don't want to overwhelm everyone with just information overload at this point. So we had a couple of discussion items that we did want to bring. I think we might keep it to this first one. I'll go through what our second discussion item would be, and we can see if we want to get into that topic, but otherwise we can also push that one to the September meeting. So the first one was something that leadership wanted to put forth for SAC consideration, a pretty just kind of general guidance from any members if you have opinions on this. So for context, MHBE always operates under a multi-year strategic plan that informs and guides the work that we do. We are currently in the last year of our 3-year strategic plan, and so we are now really getting into the process of developing a new and updated strategic plan for the coming years. And our MHBE board, their next meeting is next week, July 21st. So they'll also be receiving an update on everything that was presented here today. They'll get the federal updates, they'll get the plan certification standard update, and then they'll be provided this, overview of the state subsidy, and we'll be taking a vote on final parameters for that. And then in addition to all of that and a couple other items, they're also going to be having a preliminary discussion about the new strategic plan at this next meeting. I think it's still in a relatively preliminary stage, but they'll be open to providing guidance on where they think we should be direction for the next coming years, especially considering all of the federal landscape, all the changes ahead in the next couple years, both to the marketplace and Medicaid. So we generally wanted to bring this to the SAC as well, let you know that this is something that we're working on and focusing on, and want to give everyone an opportunity at this meeting. If you have some initial thoughts or ideas on things we should be thinking about or focusing on with all this context of the landscape in the next couple years, we welcome your input at this meeting. So I will open the floor up. We can kind of leave this to an open discussion if anyone wants to throw out ideas or wants to let us know something that you'd like us to translate to our board members as something that you want them to consider. So I'll open the floor up. Please feel free to raise your hand or unmute yourself. Stephanie, go ahead.
Thank you. One thing that I think would be great to raise up is Maryland's easy enrollment program, and how, especially under the new landscape we find ourselves in, how we can leverage it to try to help mitigate some of the impact from the federal rule and from the reconciliation bill to help people who are struggling to keep or get into coverage, how they can use the easy enrollment program at tax time or through their unemployment insurance forms to get into coverage.
That's a great idea. I think a big focus will be what we can do to mitigate impact, and the easy enrollment programs are definitely a good avenue for that. Do we have other thoughts from other members? You can throw out any ideas. Again, we're in the preliminary stages. I think it's a wide open opportunity to provide input.
What's the time frame after the initial board discussion on July 21st? When do you expect to have the final strategic plan approved?
That's a great question. I don't know the answer to that. I'm not sure if there's any other MHBE staff on this call that could answer that. If not, Allison, we can get back to you, and I'll note that as a follow-up item for everyone. So we'll give an overview of the timeline, and I'll remind everyone too, if you don't have a comment today and want to email anything, you can always do so as well. And
Yeah, and that's after the 21st as well.
yes, yeah.
Okay. Thank you.
Thanks, Allison. And Elizabeth?
Well, first of all, kudos on fantastic presentations today. This was a lot of work for you as well. And I just appreciate how clear and thorough everything was. In addition to leveraging the new tool to the easy enrollment tool, I worry most about people that are only going to discover they're uninsured when they try to seek medical care. I know you mentioned earlier that your marketing team was working on this, but I think it is very important to get on the board's radar that the communication, I'm especially thinking about DACA recipients, the million and one ways that we could possibly, I just think in these scenarios, there's no such thing as over communication. And I just wanted to, raise that as a very important point.
Yeah, thank you. And we have a great marketing team. And I think just because a lot of the provisions and changes are happening, not just now, but over the course of a couple of years, that's definitely a point well taken. Thank you. Stephanie?
Thanks. Well, I wanted to just inject some appreciation for the work that was done to expand the authority of Maryland's Prescription Drug Affordability Board. Michelle's input was really hopeful this year, and we are excited that hopefully next year the board will be able to set up our payment limits for high cost drugs for all Marylanders, and hopefully that'll help stabilize premiums, since prescription drug costs are such a big factor in rising premium costs. And I just wanted to let everyone know that we see raising revenue for expanding and protecting access to health coverage as a very important issue at Maryland Citizens Health Initiative. And we're working with the Chesapeake Climate Action Network to build a coalition of supporters for the Renew Act, which would assess big polluters and put the funds raised, among other things, towards protecting and expanding access to health coverage and health equity programs. So I just wanted to let everyone know.
Thank you, Stephanie. Any other thoughts on this discussion item? Okay, I think we can maybe leave this here for now. I will send out a follow-up to this meeting just on a couple items and reiterate that we welcome your input on any considerations for our strategic plan. You're welcome to email me at any time in the next couple days or weeks as we're going through this process. So this is obviously not the only time to give feedback. We welcome it at any point. And thank you for those who gave some feedback today. We will definitely be passing that on. We did have one more discussion item. I think just because this has been a really presentation heavy meeting and we are currently lacking quorum with the SAC and would love to have more engagement on this, maybe with more members present. I know it's July and it's season of vacation. So for time's sake and for those reasons, I think that we could push this discussion to September. Essentially what we wanted to bring to the SAC, which I think we've done last year as well, and given updates on some of this work that we're doing, but we are planning quite a few plan shopping consumer user experience updates that will help improve the kind of plan shopping and enrollment process for consumers and ease burdens, make it a little more clear and understandable. There's always those pinpoints in the enrollment process. We know it's not always simple and provides a lot of administrative burdens for consumers. So there's a lot of things that we're considering that would improve the understanding of the whole process and just kind of improve the overall user experience for consumers. So there's a couple items like we have our anonymous browsing plan shopping tool where you don't have to go through an application. You can just use the anonymous browsing tool and input some information and get to the plan shopping page to see all of the available plans that we offer on the marketplace. This tool includes providing estimates for eligibility for financial assistance. It allows you to input specific providers and check which plans those providers are covered in network under. It provides a drug search where you can input selected prescription drugs and check if those are covered under each plan, among a couple other, subsets of tools within the larger tool itself. So there's a couple of things that we're considering to improve this process. We are looking at improving our provider directory. We've received feedback on the functionality of that throughout the last couple of years. In particular, one of the improvements to the directory is allowing consumers to be able to search not just for individual providers, but for in-network facilities as well. We've been looking at various ways to improve the functionality of our prescription drug search within the tool. We're looking to improve how we actually display the plan tile to make sure that it's easy to understand and consumers can really pick apart the differences between each plan in a way that's easy to digest and more consumer friendly. And then we have been considering for a while and have incorporated this into work group discussions over the last year about how we could potentially provide tailored plan recommendations to consumers with the plan to help with plan choice and reducing choice overload and just kind of making the tool and the user experience as helpful and supportive as possible. So if I'm happy to open the floor up if anyone has any initial thoughts. We were interested in getting SAC feedback on what you think are priorities among all these different buckets. If there are some not included here that you think should be included, but we are kind of focusing on these 4 items in the next year and wanted to get some feedback on thoughts from other SAC members on this as well. So we do have a couple minutes. I'm happy to open the floor for a little bit if anyone has any initial thoughts. Regardless, we'll continue this conversation in September, but please feel free to share any initial thoughts in the next couple minutes. I'll open the floor.
I'll prepare much more detailed feedback for our next meeting once I actually delve into the consumer plan shopping tool. But the idea of allowing you to search for facilities in your area, I think is excellent. I'm also just thinking about, not just like within, I'm not sure how it's set up, if it's, the mile radius or is it by zip code, but proximity to public transport as well, to just to take make it as easy as possible for somebody to find an in-network facility near them. I think would be fantastic.
Thanks. I totally agree. Any way that we can incorporate transit friendly support into our tool is always wonderful. Transit is a big part of healthcare access. So I love that point. Thank you for the initial feedback. And I think we can push this to September, and I think it would be helpful for everyone to be able to review this. But thank you, Elizabeth. And any other additional comments, I'll give it another minute. Okay, I think we might be a little tapped out for today. But thank you again, everyone, for your feedback on all the different discussion items, all the different presentations. I know this was a lot to cover. It's a pretty busy time right now, but we really value your feedback and your participation in this group. So thank you to everyone. I will hand it back to Mark to move for public comment, and I think we can close out.
Thanks. Yeah, so we'll pause for a moment to see if there's any public comment. All right, well, hearing none, I think we can close out. So thank you, everyone, and look forward to seeing you next meeting. Thanks.
Thank you.
Thank you.
Thanks, Mark. Thanks, everyone.